Congenital heart disease with left to right shunt. Michael Peters. Department of Diagnostic Radiology, Bloemfontein. Overview: classification of congenital heart lesions. Factors that influence lesion presentation. Imaging chain sequence. Left to right shunt lesions. Anatomy. Physiology. Imaging. Classification of congenital cardiac lesions. Shunt lesions. Right heart lesions. Left heart lesions. Abnormal origin of the great arteries. Factors that influence lesion presentation. Age of child. Severity of the lesion. Example, VSD. R to L shunt up birth. L to R shunt with CCF as age increases. The anatomy of the lesion remains constant. Radiographic features and clinical findings change with time. Classic radiographic features of certain lesions, rarely seen. Imaging chain sequence. The imaging sequence varies with age, clinical presentation, type of lesion, echocardiography, chest radiography, CT, MRI, angiography, congenital cardiac left to right shunt lesions. ASD, VSD, PDA, ductus arteriosus aneurysm, aorticopulmonary window, cardiomegaly on CXR, AS's pulmonary vascularity - increased, read history - a cyanotic patient, DDX, ASD, ABSD, VSD, PDA, aorticopulmonary window. ASD 10% of all CHD incidents, twice as common in females. Secundum defects, likely genetic cause. Holt or Familial ASD. ASD anatomy: 3 primary types. Relationship to the fossa ovalis. Secundum defects, 80%. Region of fossa ovalis. Ostium primum defects, 10%. Caudal to the fossa ovalis. Sinus venosus defects, 10%. Posterior to the fossa ovalis. Insert Fig 90-1. ASD - sinus venosus defects. Not true ASDS. Defect in the septum which separates the sinus venosus portion of the RA from the right pulmonary veins and systemic veins. Most often found in the wall between the posterior inferior border of SVC and RA. Commonly associated with anomalous connection of right upper, middle or lower pulmonary veins draining to the RA or SVC. ASD - sinus venosus defects. Much less commonly, defect is found in the wall between the inferior RA at its junction with the IVC, associated with anomalous connection of right middle or lower pulmonary veins draining to the RA or SVC. ASD - coronary sinus septal defects. Rare spectrum of lesions. Partial or complete absence of wall between coronary sinus and LA, associated with the left SVC draining to the coronary sinus. Blood shunts from the LA to the RA via an unroofed coronary sinus. ASD - patent foramen oval. Located between septum secundum and primum. Normally patent prenatally. Allows O2-rich blood from ductus venosus, greater than reach LA. Sealed after birth. Increased LA pressure versus RA. Probe patency. 25% of adults. Functionally closed. Right to left shunt possible, Valsalva. ASD - common atrium atrial septum completely absent. Common in visceral heterotaxy syndromes. ASD, physiology: left to right shunt volume determined by ASD size, left heart compliance, pulmonary vascular resistance, Large defects show increased size of RA, RV. Pulmonary artery. Right to left shunt will occur when pulmonary vascular resistance greater than systemic vascular resistance. ASD-clinical presentation. Detected 1 to 2 years of age. May present earlier at 6 to 8 weeks with murmur. Older children with large ASD. Fatigue and dyspnea. Split-second hard sound, no variation with respiration. Diastolic flow murmur. Adults, flow-related pulmonary arterial hypertension. ASD imaging, echocardiography. Modality of choice for DX. Localizing. Size. Shunt direction and severity, color Doppler. Right ventricular qualitative function. Septal bowing, right to lieutenant. Points to volume overload. ASD imaging, echocardiography. Right ventricular pressure. Assessed by evaluating the degree of tricuspid regurgitation. Septal systolic position, systolic septal flattening, increased Harvey pressure. PFO. DX, flap valve or saline injection to right heart plus Valsalva. Right to lieutenant shunt on Valsalva. T. ASD imaging, chest radiography. Neonate. Normal cardiac size. Normal pulmonary flow. Later infancy and childhood. Mild cardiomegaly. Triangular cardiac silhouette. Left atrium normal. Distinguishes uncomplicated ASD from other L greater than R lesions. Main pulmonary artery enlarged. Eisenmenger syndrome findings. Seen in pulmonary hypertension. Large central pulmonary arteries. Peripheral pulmonary artery tapering. Fig 90 to 2 triangular cardiac shield Fig 90-3. ASD imaging, chest radiography. Mild to moderate cardiomegaly. Increased pulmonary vascularity. No left atrial dilatation. Fig 90 to 2 triangular cardiac shield Fig 90-3. ASD-imaging angiography MRI scene phase contrast sequences. Assess hemodynamic consequences of ASD or use if transcatheter closure is planned. MRI. Adjunct to echo. Greater than 90% sensitive and specific for ASD localization and detection. Useful in PT with poor acoustic windows. Can lead to ASD being misdiagnosed. Atrial septum is thin on BW images, rather use MRI scene. G in steady state free precession scene, shows turbulent jet over ASD. Scene phase contrast sequences. Show direction and amount of shunting. ASD-MRI dynamic perfusion study. PFO can be demonstrated by injecting gadolinium into the right heart plus Valsalva. ASD hemodynamic evaluation. Demonstrates Eisenmenger syndrome physiology. Contrast seen crossing the atrial septum from the RA to the LA. AVSD 2 to 5% of all CHD. 40% of Down syndrome patients have CHD. 40% of Down's PT with CHD have AVSD. Associated with visceral heterotaxia, asplenia and polysplenia syndromes. Ellis Van Creveld syndrome, AVSD lesions associated with AVSD PDA, 10%, tetralogy of Fallot, 6%. Transposition of the great arteries. Doubled outlet RV. Aortic coarctation. AVSD, anatomy abnormal development of the endocardial cushions. Mild form, partial AVSD. Crescent-shaped defect in the inferior portion of the atrial septum adjacent to the avenue, valves. Cleft mitral valve. Separate mitral and tricuspid valve orifices. Fig 90-7. AVSD, anatomy complete form, unbalanced AVSD single avenue valve. Ostium primum ASD just superior to the plane of the avenue, valve. Large VSD beneath the plane of the avenue, valve. Cleft in the anterior leaflet of the mitral valve. Cleft in septal leaflet of tricuspid valve. The common avenue valve has 5 leaflets. Shortened left ventricle inlet. Left ventricle papillary muscle defects. Abnormally close to each other are only one papillary muscle. Unbalanced AVSD. Relative hypoplasia of one of the ventricles. AVSD, physiology complete AVSD. Left to right shunt, related to size of defect and pulmonary vascular resistance. Shunting may be interatrial or interventricular. Cleft mitral valve leads to mitral regurgitation in CCF. Pulmonary hypertension develops, more common in Downs PTS. AVSD presentation infants with complete AVSD, partial AVSD. Tachypnea, tachycardia. CCFSX when pulmonary resistance starts to fall. Signs and symptoms vary according to the degree of shunting. Partial AVSD. Infants usually asymptomatic. Can present earlier if severe mitral incompetence. AVSD, imaging echocardiography. Accurately demonstrates AVSD components. Ostium primum defect. Inlet portion of the ventricle. Abnormal valve leaflet morphology. Papillary muscle architecture. Shunt level and flow direction. Ventricular function and size. Evaluate for outflow tract obstruction. Pulmonary and systemic venous anatomy must be documented because of frequency of associated heterotaxy abnormalities. AVSD, imaging chest radiography moderate to marked cardiomegaly. RV and RA enlargement, more incomplete AVSD. Increased pulmonary vascularity. Left atrial enlargement, if associated mitral incompetence. Lung infiltrates, increased pulmonary blood flow associated with recurrent LRTI. Lung hyperinflation, seen with large left to right shunts. Due to increased blood volume with increased overall lung volume as well as increased airway resistance from enlarged arteries and veins. Fig 90-8. AVSD, imaging chest radiography cardiomegaly pulmonary plethora. Fig 90-8. AVSD, imaging cross-sectional imaging CNA phase contrast MRI. Not needed in initial DX. Used to confirm DX and evaluate the size and morphology of the atria, leaflets, ventricles and great vessels. Evaluate ventricular function. CNA phase contrast MRI. Assessment of shunt fraction, QP/Qs. Valvular function. 90 to 9, 90 to 10, AVSD, imaging angiocardiography long axis ventriculogram. Rarely necessary for DX. Use if DX is unclear or hemodynamic information is needed. Long axis ventriculogram. Gooseneck deformity of left ventricular outflow tract. Anterior superiorly positioned aortic valve. Elongated and narrowed LV outflow tract. 90-11. VSD 20% of all CHD 2/1000th live breaths. VSD plus complex CHD account for greater than 50% of CHD. Most common lesion in trisomy 13, 18 and 21. Incidence slightly higher in females. Incidence varies on age of evaluation. Most small VSDs close spontaneously. VSD isolated or is part of complex CHD tetralogy of Fallot. Truncus arteriosus. ASD. Coarctation of the aorta. Tricuspid atresia. Transposition of the great arteries. Doubled outlet RV. VSD, anatomy for components of the ventricular septum. Inlet septum. Muscular septum. Outlet septum. Membranous septum. VSD involves one or more component. 90 to 12. VSD, anatomy and left septum. Muscular septum. Outlet septum contains avenue valves and their attachments, formed from endocardial cushions. A VSD defect location. Muscular septum. Trabeculated portion of RV, viewed from RV. From tricuspid valve leafless RV apex and crista supraventricularis. Location of single or multiple muscular defects. Outlet septum. Extends from the crista supraventricularis to pulmonary valve, viewed from RV. Membranous septum. Inferior to the right and non-coronary cusps of the aortic valve. 80% of VSDs involve this area. VSD, physiologic effect determined by small defects. VSD size. Right and lieutenant heart compliance. Pulmonary vascular resistance. Small defects. High flow resistance. Large defects. Low flow resistance. High blood flow in the pulmonary vasculature. Leads to pulmonary vascular obstructive disease. VSD, symptoms dictated by VSD size. Degree of left to right shunt. Typical signs in greater than 1 month of age. PSM is pulmonary resistance falls. No murmur in large VSD. Loud split-second heart sound. Significant shunt. Failure to thrive. Dyspnea. CCF. Irreversible pulmonary vascular obstructive disease. Shunt reversal, VSD, imaging echocardiography method of choice. Used to assess the location, number and size of VSDs. Shunt assessment. Color Doppler is useful to identify muscular VSDs. RV plus pulmonary artery pressures measured. Right plus lieutenant heart volumes are measured. Tricuspid and aortic valves. Assessed for possible tethering of the valve tissue into the defect borders. T used if poor acoustic windows. VSD, imaging chest radiography findings depend on VSD size. Small VSD, may have normal CXR. Moderate to large VSD. Cardiomegaly with LA, LV, RV enlargement. Enlarged pulmonary arteries. Increased pulmonary blood flow. CCF frequent in infants plus large defects. Older children, pulmonary hypertension likely. Large central pulmonary arteries. Pruned peripheral pulmonary arterial branches. VSD, cross-sectional imaging. Echocardiography usually sufficient. Muscular VSD sometimes detected on routine CT chest. MRI. 90% accuracy in VSD detection. Larger defects seen with spin echo or double inversion recovery techniques. Smaller defects seen with GE or steady state free precession images. VSD, cross-sectional imaging. MRI. Shunt evaluation. Cine phase contrast measurements in aorta and pulmonary artery. Right plus lieutenant ventricular stroke volume comparison. Quantitative assessment. Right and lieutenant ventricular function. Right and lieutenant ventricular volumes. Ejection fractions. Evaluation for extracardiac vascular anomalies, VSD, imaging angiocardiography. Used to assess pulmonary vascular resistance. Quantify intracardiac shunting. Evaluate for ventricular septal defect anatomy. Evaluate the coronary arteries. Evaluate for associated valvular and vascular anomalies. Angiocardiography used if echocardiographic evaluation was insufficient or if transcatheter VSD closure is planned. PGA 5 to 10% of CHD1 1600 live births twice as common in females. 20 to 30% of PRMs have PDA. Often associated with VSD. Aortic coarctation. Aortic stenosis. Mitral regurgitation, PDA, Anatomy: persistence of embryologic sixth aortic arch. Sixth aortic arch connects lutein pulmonary artery with descending aorta. PDA may be on the right with a right arch. PDA, anatomy: ductus arteriosus, aorta angle. Acute angle seen in isolated PDA with pulmonary atresia. Ductile dependent pulmonary flow. Obtuse angle seen in non-ductile dependent pulmonary flow. 90 to 17. PDA: prostaglandins and O2. PG: keep the duct patent during fetal life. At birth blood, O2, rises and, PG, lowers. Functional ductal constriction. Complete closure at 2 months. Ligamentum arteriosum remains, may calcify. In premature infants, closure is delayed due to less sensitive ductal tissue to O2. Respiratory distress, hypoxia, greater than increased, PG. In full-term infants. Rubella. Asphyxia. Genetic and environmental causes, PDA, physiology: amount of lutein to right shunt dictated by ductal length and diameter. Degree of pulmonary hypertension. Untreated PDA leads to pulmonary vascular obstructive disease. Prim with no significant lung disease. Systolic high frequency murmur. CCF, large shunt. Prim with significant lung disease. PDA prevalence greater than 80%. Almost inaudible murmur. DX with echocardiography. PDA, physiology: term infant with small PDA. Usually asymptomatic. Murmur present. Infant with moderate to large PDA. Continuous machinary-like murmur. FTT. Poor feeding. CCF. Irritability. PDA imaging: echocardiography, chest radiography. Standard imaging technique. PDA size and diameter. L greater than R shunt fraction. Degree of pulmonary hypertension. Can identify complicating factors, ductal aneurysm or calcification. Chest radiography. Premature infants. Pulmonary edema. Cardiomegaly. Plus associated lung disease. PDA imaging: chest radiography, term infants. CXR may be normal. Term infants with significant shunting. Cardiomegaly. Increased pulmonary blood flow. Consider PDA in a prim infant with increasing granularity of lung fields. Increasing heart size on serial imaging. 90 to 18. PDA, imaging: chest radiography, prominent ascending aorta and arch. Helps differentiate ASD and VSD from PDA. ASD and VSD have a normal aortic arch. Ductus bump. Prominence of the descending aorta. PDA, imaging: cross-sectional imaging. Reserved for complicated cases to define anatomy. CT, MRI: ductal size and length. Cine phase contrast sequences. Can quantify the amount of flow through the PDA. PDA, imaging: angiocardiography. Reserved for cases where significant pulmonary hypertension is suspected. Assess pulmonary vascular resistance. Ductal morphology of transcath. Closure planned. Aneurysm of the ductus arteriosus, DAA. 1.5 to 8.8% of full-term infants. Usually DX prenatally or after birth in asymptomatic patients. Possible association with connective tissue disorders. Ehlers-Danlos syndrome. DAA, anatomy: saccular or fusiform dilation of the PDA. Etiology unknown. Intrinsic weakness of wall of the duct. Delayed closure of aortic sided duct with exposure to systemic pressures. DAA, imaging: chest radiography, echocardiography, MRI/CT or angiography. Ductal bump in area of main pulmonary artery and aortic arch. Echocardiography. Most often modality used for DX. MRI/CT or angiography. Rarely used to confirm the DX. Aorticopulmonary window. Rare-0.2% CHD. 30 to 50% associated with other abnormalities. VSD. ASD. PDA. Tetralogy of Fallot. Interrupted aortic arch. Aortic coarctation. Subaortic stenosis. Anomalous coronary arteries, pulmonary trunk erosion. Aorticopulmonary window anatomy. Incomplete division of the primitive common arterial trunk. Two distinct semilunar valves. Large oval communication between ascending aorta and pulmonary trunk above the aortic valve. Aorticopulmonary window Mori classification. Mori type I. Involves the proximal medial wall of the ascending aorta. Mori type II. Involves the distal posterior wall of the ascending aorta. Mori type III. Involves the medial and posterior walls of the ascending aorta. Aorticopulmonary window, physiology. Large high pressure Lieutenant right shunt. Presence in first weeks of life. CCF commonly seen. Systolic ejection murmur may be heard. Diastolic murmur, associated pulmonary insufficiency. Bounding pulses frequently encountered. Aorticopulmonary window, imaging. Echocardiography. Method of choice. For evaluation of defect anatomy. Relationship to the aortic and pulmonary valves. To define coronary anatomy. Pulmonary pressure and ventricular function. Other defects. Chest radiography. Mimics PDA on CXR. Cardiomegaly. LA plus LV enlargement. Increased pulmonary blood flow. Prominent ascending aorta and pulmonary artery. Aorticopulmonary window, imaging. Cross-sectional imaging. MRI and CT can depict APW anatomy. Used as adjunct to echo. Shunt volume quantification. Ventricular function evaluation. Angiocardiography. Confirmed DX of echo questioned. Use if pulmonary pressures are needed to be determined. Critical to differentiate from truncus arteriosus, APW has two distinct semilunar valves. Summary echocardiography MRI, CT/CXR angiography mainstay. Complicated cases. Also yields good physiological information. CXR. Useful for screening. Angiography. Complicated lesions. Usually used where catheter angio intervention is planned.